Ceribell, I wanted to cover when we should be thinking about seizures, especially non-convulsive seizures, obviously, and the new workflow to make sure that we call the readers systematically. There's an order in Epic, and we need to review that together. Then I can demonstrate it with a headband that I have here, and then I can move to E64 for people to have a feeling on the recorder and having the headband in their hand. But to start with just when do we consider non-convulsive status epilepticus or seizures, let's review a few slides so that we speak the same language. So again, for those who don't know me, I'm Greg Kapinos. I train in neurology, but my interest in teaching all the different disciplines, like whether you're an internist, an EM physician, a PA in neurosurgery, or in neurology, comes from my training in neurocritical care. And in 2009, I told the Neurocritical Care Society, as well as other entities, to start thinking about a neurological version of the ACLS and the ATLS. We should have a neurological version, and now we do. It's called the ENLS by the Neurocritical Care Society for the management of cardiac arrest and cooling devices. But for today's talk, it's true that there was a poor training overall nationally in terms of having all PGY1s and all APPs knowing what to do for status epilepticus, the basic of EEG, the anti-seizure regimen, and the sedatives. So that will be pertinent to this talk today. What is a seizure? It's a change in the behavior of our patient as a consequence of a brain electrical dysfunction. It's a hypersynchronization of the neuronal networks, and we should not use the word really epilepsy until there is multiple seizures and a disorder that is diagnosed as a propensity to have seizures in the future. So anti-epileptic drugs, you'll hear me say don't use that term because there's no real medication that is curing epilepsy or removing completely the risk of having seizures. Anticonvulsant is also a misnomer because convulsions are only one subtype of seizures. There's non-convulsive seizures, so a proper term would be anti-seizure medication. Psychogenic and real and brain attacks are probably very also not proper denomination. But when you don't have electrical abnormality and you have a spell, indeed, it could be psychogenic. Versus what we are going to focus on is when there is hypersynchronization of neural networks and you have this EEG correlate to the clinical abnormality. Very briefly, as you know, I hit the AAO times 3, and I think domains of consciousness should be detailed along those 5 domains here of arousal, attention, intention, memorization of the events, and being aware of what is going on in your surroundings and in your own body. And the same way, there's no altered lung function or altered cardiac function, and people talk about shock or tachycardia or respiratory insufficiency or respiratory failure or an AA gradient, we should never call a neurology consult or a neurosurgery PA should never come to assess a patient just for an altered mental status. I wish we were more precise in saying which of the domains of consciousness are altered. Let's skip all that. You all know that simple partial seizures, depending on where it's coming in the brain, will trigger some neurological deficits or exhibits of whatever that region of the brain is responsible for. So you can have visual hallucinations, you can have focal motor status epilepticus, you can have grimacing, sensory dysfunction. So seizures can be convulsive, convulsion, we all know what that means. That can be more subtle, by the way, rhythmic movements, twitching, and they can be completely non-convulsive or subclinical, or if you prefer, an EEG captured seizure. When we see what is going on clinically and we see what is going on the EEG synchronously, then we can talk about a correlate. So if a patient is having, even if it's not a convulsion, not even a rhythmic movement, but a blank stare or a weird feeling, and they report to us, I'm feeling like something in my epigastric area or butterflies or what have you. At the same time, we have an EEG correlate and we see that there's spike and waves. You can call it definitely an EEG correlate or a seizure. Epilepsy, as we said, is reserved to the condition of having a propensity to have seizures. So what we're going to go over quickly is epileptiform discharges, and then I'll show you how to apply your own point of care EEG to detect those abnormalities. What is an epileptiform activity? It means that it looks like epilepsy, or because I told you we don't like the term epilepsy, I think the future versions of ACNS guidelines will talk about ictiform, or something that is looking like an ictus or a seizure. But for now, we're continuing to use the word epileptiform. So activity on the EEG that looks like what we see in an epileptic patient is basically something spiky or hypersynchronous of neurons. That can be also rhythmic. So rhythmic delta activity, spikes or spike and waves are definitely what we call epileptiform activity. A highly epileptiform pattern means that it's not a seizure, but it's looking really angry enough that it needs to be treated. So there's a continuum. It's not black and white of binary. This is a seizure versus not a seizure. Sometimes you are in between and you need to treat it as such, as if it was a seizure. You can call it near ictal too, or angry, but the proper term in the nomenclature is a highly epileptiform pattern. So there's a definition of what is definitely not ictal, and in epileptic patients we see it between the spells. So it's why it's called interictal. A better term would be non-ictal, and it is laying here on that axis. And you have what is definitely on an EEG a seizure, so it's spike and wave accelerating and spreading in geography of your brain, and that tells you that is definitely a seizure. And there's that gradation from what is non-ictal to what is definitely ictal on one axis, which is the y-axis here, but or the x-axis, sorry. And then people also complicated the story even more at Columbia 20 years ago with Hirsch and others, and Jan Klassen published that actually we should consider a second axis, which is how much injury to the brain there is. And sometimes you can be very benign, like triphasic waves, but if you put a probe in the brain and you see that there is deleterious impact onto the neurons, it's actually a highly deleterious pattern that needs to be treated like a seizure. So whether you're ictal or deleterious to the brain, you need to be treated. And there's this diagonal, basically, threshold here that is conceptually the thing we're assessing to decide on treatment. Very briefly, what does an EEG look like? It's squiggles where we talk about the amplitude, which is on the y-axis here, how many microvolts you see. And finally, on the x-axis, you have a time. Usually on one page, you see 10 seconds, and between each of those bars, you see 1 second, and therefore you're defining one wave that goes to the next, and that gives you a per second or hertz. So here is very fast and low amplitude activity, beta, which is usually in the forehead, alpha in the back of your head, and when you see that, that's actually an alert state. When you become drowsy, you see higher amplitude, seesaw looking things, and that activity is between 4 to 8 per second, or 4 to 8 hertz between that bar and that bar here. So that means you're having theta activity. That can be drowsiness or moderate encephalopathy. Finally, when you fall asleep, you go into a delta wave where there's only one wave per second, 1 hertz, let's say. It can go up to 4 or 3, and it is usually very ample. So you see the amplitude here is many microvolts, like 200, 300 microvolts, as opposed to 50 microvolts or 20 microvolts here. Muscle artifact will look like even more like this, like sizzling, um, low amplitude and fast frequency. So what is an epileptiform discharge? It's something that catches your eyes, a spike and a wave, or a spike like this that disrupts the background. When we talk about burst suppression pattern, it means a burst of activity and then a suppression or a flat line, a burst and then a flat line, a burst and a flat line. It's not a suppression of the burst, so don't put a hyphen, because in English, if you put a hyphen between two words, it means that there's the second word has an impact on the first one. So burst suppression is not a suppression of the burst, but it's an alternation. So you should put a slash actually between the burst and the suppression word. It's a burst and suppression and alternation between the two. A burst, a suppression, a burst, a suppression, a burst, a suppression. Don't think that necessarily just because you have burst suppression pattern, you are controlling your seizures. You can have angry bursts or highly epileptiform burst, and that is not adequate control of the ictal activity. So this is the way I teach PEAs and rounding residents with me on the very basics of epilepsy. When you look at your EEG, you should see that something catches your eyes with a spike here, a spike here, a spike here. Then when it's one area of the brain, you call them lateralized. Let's say the left frontal area has periodic discharges. They used to be called PLEDs, now they're called LPDs, lateralized periodic discharges. When they're on both sides of the brain, the left area and the right hemisphere, both have epileptiform discharges. They're bilateral, but they are independent. They're not synchronized. They're called bilateral independent periodic discharges. And when they're perfectly synchronized, always happening on both sides of the brain at the very same time, and they have the same morphology, they're called generalized periodic discharges. So what is a seizure? A seizure will be that it is rhythmic activity that is accelerating. So here is an epileptiform discharge, or a discharge if you prefer, to get rid of the word epilepsy. For instance, here a spike and wave, and let's zoom in 1 second. Between that bar and that bar here, you have 1 second. If you see a spike and a wave, a spike and a wave, and a spike and a wave, that means you had 3 hertz, 3 spikes per second. That is, if it's lasting for more than 10 seconds, it could very well be a seizure. When you are within delta activity and you have rhythmic delta activity, you can go from one wave to the next. That defines the word rhythmic. And if that is sustained and evolving over time for more than 10 seconds, you will also call that a potential seizure. So if you transform those spikes into a blip, that's how I'm bridging to Ceribell, you will hear what is the sound of a seizure. So Parvizi, an epileptologist at Stanford in 2009, was starting to think, because he's a musician also himself, why don't I transform those spikes into a blip? And then I can teach residents how to recognize the sound of a seizure, which would be the following. If it's repetitive, it's gonna sound like it's shivering or quivering. And if it's accelerating over time, you're gonna hear that acceleration. And then there's usually a fluctuation, and then it stops. And also because it spreads in geography of your brain, you're gonna hear that it's louder and louder. So a seizure will be sounding like the following. So if each blip is a spike, when you hear blip blip, that's just what 2 discharges here and there. That could be very well an artifact. However, if you're starting to hear, if you transform the EEG into a sound system for listening to the brain, you're gonna hear blip, 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 and then you see the definition of a seizure will be blip, 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 blip. More than 10 seconds, an acceleration, a spread in geography, the amplitude was louder, and then fluctuation, and then a slowing down, and then it stops. And usually you have a postictal refractory period where there's no sound at all. So very briefly, I hope you see a lot of squiggles. That's the background right there of the patient. And then what should catch your eyes is those spikes, 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 spikes. Every 1 second here, there's periodic discharges that are appearing. Here is a more blunted epileptiform discharge. It's less spiky, it's more round, but it is still a blunted epileptiform discharge, and it's periodic. It comes back. You know when is going to be the next one here, right? Because you know it's 1 second, 1 second. So sure enough, 1 second later, you're going to get your 4th epileptiform discharge that's going to show up there. So you have a periodic pattern. Here are real periodic patterns, because not every spike is truly coming from the brain. But if you have a phase reversal from the forehead to the back of the head, FP for the forehead, F for central, F for frontal, C for central, P for parietal and occipital. If you go from the right forehead to the right occiput of this patient, you see a progression here, like a QRS of the anteroseptal progression of on an EKG. That means that 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 wave is truly coming from inside the brain, inside the cortex. So that's a phase reversal, a real epileptiform discharge, as opposed to, I can give you other examples where it's not seizures. This is a seizure that is at the onset right there in the right temporal region. This is a seizure, but it's masked because also the patient started shaking. So you see myogenic artifact overlaying the seizure. Here is a seizure coming either in the right, yeah, I think it's right central, then right temporal. So you see the spread in geography. You see it in the right central region, then in the right temporal lateral region, and then it's going to spread even to the left side. Here are some generalized periodic discharges of high amplitude, a little bit triphasic morphology. Here is also some spiky activity, some spikes, some polyspikes, meaning there's a spike, and then finally a wave. That's what you see after cardiac arrest a lot. Here is a lot of activity that is very rhythmic. You see 1, 2, 3, 4, 5, 6 hertz that starts with a sudden onset here and spreads from one channel to the next. That's the onset of a seizure. But not everything that is spiky is a seizure. Here, it's actually not with a phase reversal. It's a mirror image. That electrode here that is shared between those two channels just came out, or the goop is not giving a good conduction of the electricity, and therefore it creates that artifact. So APPs have been embracing the technology for a long time at UCLA. I think that's at least a 10-year-old picture. Ceribell was used as a screen without calling neurology or neurosurgery or neurocritical care. Everybody that thinks about, hey, why is my patient a little bit off? Sometimes he's looking at me in the eye, sometimes he has blank stares. I think it is an excellent screening tool to use your own stethoscope of the brain with the Ceribell. So now let's go to the actual workflow. So you identify a patient that is having altered mental status, even if I hate that term, as I said, but really, like, if it's blank staring spells, or sometimes he's looking at you, tracking you, sometimes he doesn't, sometimes he's speaking, sometimes he doesn't, sometimes his behavior is off, sometimes it's better. That could be delirium, but it could be also non-convulsive seizures. So you identify that there's a change in the mental status or the behavior of your patient, especially if it's on-off of being aware. You should order the Ceribell. Remember to always order first. Go get your Ceribell in the unit. There's 2 in the adult ED, 1 in the pediatric ED, 2 in the CQ, 2 in the MICU, 1 in A4, 1 in the pediatric observation monitoring unit, and 1 in the pediatric ED. So we have a dozen Ceribells at Elmhurst. And I'll show you how to apply it to the head later on this video, as well as in E6-4. But when you apply it, within 2 minutes, you know if your patient is seizing or not, because in status epilepticus, you're going to hear that sound when you press the stethoscope function. It's going to transform the spikes into those blips. And if you hear blip, 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 your patient is in status. You can even not necessarily call a neurologist or teledocs to get the read. Go ahead, you've identified a seizure. Please give the lorazepam stat. Give a heads up also when you're ordering. Now the new workflow is that you should call the reader. Even if you haven't applied it on the head yet, it's better to call the reader. So when it's a neurosurgery patient and I'm on the case, you can just call me and I'll give you the read. When I'm not on, or as a default mode, off hours or in the ED, or if we're not even consulted on, I tell internists to rely on teledocs, which is a service of basically some readers of Ceribells nationwide that provide those reports in Epic. When you continue the recording, 65% of the time there's not going to have any seizure, so don't worry. After 2 hours, you can turn it off. When there is an equivocal pattern, you should probably get teledocs or me a call, and I will tell you if that deserves to be treated or not. And when it's red, don't worry. That listening of the EEG doesn't have to be permanent, because otherwise you would have to stay at the bedside for 2 hours. You can just listen to the brain for 10 seconds seconds on each side, and then you go back to your call room. If 5 minutes later the patient will enter status epilepticus, don't worry, you don't need to be listening at that time. The onus will be number one on the reader, because you will have called me or Teledocs to give you to give me a heads up, and we will tell you, oh, now he entered status epilepticus. Or the screen will also alarm the nurses. So at the bedside, if the artificial intelligence is listening to the brain and recognizing that pattern, it will flash in red status epilepticus, and it will make a sound. So the Ceribell recorder will alarm the bedside team that there is seizures. You can give then immediate also treatment with lorazepam, and then load the Keppra. Um, After 2 hours, you should remove that, because I will show you that those electrodes are a little bit bendable, but they're still plasticky and rigid enough that if you leave it for 12 hours in a fragile skin patient, you will get some pressure ulcers. So let me go over that workflow and show you those electrodes. So as we said, always order in Epic first. When you put it in the Epic system, it asks you actually two areas for a phone number. Your phone number, so if you're the resident, the PA, it can be the ED physician, it can be the internist on B3 or B6 on a oncology patient that suddenly they're thinking, hey, I want to know if their blank staring spells are actually seizures or not. They should enter their own phone number. Whoever is applying or putting in the order should put their phone number, their beeper or what have you, and also the unit phone number, because sometimes they're not easily reachable. So we double that phone number. The reason is redundancy is better, because the teledocs were always complaining of not being able to reach out to the bedside team to inform them that there was status epilepticus. Subsequently, also, we empowered the transfer center of H&H to be reached out by those teledocs, because when we're relying on those outside readers, sometimes they were having trouble identifying which unit to call back, and nobody was picking up the phone, especially in an ICU or in the ED. We all know sometimes there's a delay in communication. So we don't want that to occur. So the transfer center will be able to reach out to whoever placed the order. They will find whoever placed the order or the attending of record, and they will let them know, hey, your patient starting at 2 a.m. had some seizures. Choose Teledoc as the default mode, but if I am on the case, if you're a neurosurgery PA evaluating a patient in the CQ or even a consult, there's going to be neurocritical care involvement. It's easier to reach out to me than those outside readers. Call Teledocs or me, the local reader, immediately, not even after applying because you want a few minutes. I know that's a logical rationale. People were telling me, I don't want to call Teledocs right away because I want them to have at least 5 minutes to review. And sometimes there's a little bit of a delay of the upload of the study on the server. But that's not a good workflow, because then people forgot to call the reader. So please call Teledocs right away when you're ordering, or the local reader, meaning usually me, or in pediatrics, it's Dr. Gorcharan, our pediatric neurologist that reads the Ceribell. Call us immediately as a heads up. Hey, I'm just applying a Ceribell. In 5 minutes, maybe you're going to be able to see it on the server and let us know if he's in status epilepticus or not. So don't call us later after X amount of minutes, because otherwise you're going to forget. So call us immediately as a heads up. When the neurologist is on the case, but it's usually me, I don't think the other adult neurologists are interested in reading at this point, so they are okay relying on the teledocs, those adjacent health services that are remote. So when the neurologist is on the case, but I should transform that is when Kapinos is on the case and he wants to read, choose local and give them a call also as a heads up. So we're not calling anytime, not later. Do not call me later based on the AI color code. I know on the server it says if it's green, it's very unlikely that it's status epilepticus. If it's orange, you should maybe have a highly epileptiform pattern that maybe needs to be treated. And if it's red, you can treat right away. I put that in the prior workflow, but I think I complicated the matter. So now it doesn't matter. Just call upon application or upon ordering the EEG and put the onus on me, the reader, or the teledocs to call you and deal with those color-coded interpretations of how likely is your patient in status epilepticus. Call upon application, if not ordering. It's okay if you applied it and then within 1 minute you come back to your desk and you're calling us, but it's okay that it's going to be a heads up, and then when you pick up the phone, I'm going to tell you, I'm sorry, but it's not on the server yet. At least it will give me a heads up, and it's going to be on me to call you once I see the EEG and I see that they're seizing. Please stop after 2 hours, as we said, otherwise there's going to be some pressure ulcers. When you end it, you press end recording, and I'll show it to you on the recorder. Where is that button? And it's going to ask you upload, and you say done. I think within a few seconds, it's uploading onto the server. Then you remove the headband in order to avoid the pressure ulcers. It was on a few occasions I've seen, oh, yes, we ended the study. Actually, they did not end the study. They just removed the headband. So it was still recording just artifact. That's annoying. But at least the patient was not exposed to the pressure ulcer risk by having the headband on them. The opposite is also true. Sometimes I call and I'm like, is the study ended? And I've been told yes. They ended the study on the recorder, but they did not remove the headband from the head of the patient. So that was good that it was ended, the study, but then you still expose your patient to the risk of pressure ulcers. There will be also some automatic treatment. So if you see that it's red and somehow teledocs are not responding and you're hesitating, it's always better to act upon the findings right away. So don't feel bad about giving lorazepam. It's a technology that has been validated as accurate, more than 95% sensitive and specific. Yes, on occasions, maybe an artifact will be overtreated with lorazepam, but it's not worth the delays in saying, hey, I was trying to figure out if it was real or not, and then next thing you know, the patient is seizing for 15 minutes, then your lorazepam will not be efficacious anymore. So act upon the findings right away. There's a label that's more for the nurses, but feel free to use it too. If you click on the little flag that is orange, it's going to ask you, what do you want to document as a label on the EEG recording? Like suctioning or turning his head, we're intubating the guy, we're doing CPR. That's very important for me because, or teledocs, when they're reading, sometimes the CPR really looks like a spike and a wave, a spike and a wave. So we will be like, oh my gosh, he started seizing at 2 a.m. and people will be laughing at us. No, it's the fact that he coded and I was doing CPR at 2 a.m. Tell us also, I think there's a little flag that says lorazepam was given, Keppra was given, so that I can see on the EEG the before and after treatment, and I can tell you if it's working or not. We'll continue to do QAs for the late discovery of studies, the late communication to teledocs. There's less issues when they call us, the local readers, so I prefer that system, obviously, and we'll do QAs and how to make it better so that we don't have any late treatment of patients. So the bandana looks like this. When you open your Ceribell, oh yeah, so the recorders, I told you where it is. 2 in the MICU, 2 in the CQ, 1 in the A4, 1 in the POMU, 1 in the pediatric ED, and 2 in the adult ED. The recorder, I'll show it to you in the room in E64 in 5 minutes, but also I want to show you how to know how to apply the Ceribell for those who cannot make it to the room over there. So when you open your disposable, which is stored also in those same areas in the disposable rooms. In the equipment room, you should see a blue bin, and it's supposed to be on par, like restocked appropriately. You should find those. The dark blue is for the adults, and the pediatrics are baby blue. You open the box and it will drive you through the steps. So it says step 1 is to pull the hair or roll a towel behind the occiput area, or actually in the nuchal area, in order to lower the pressure on the occiput, because even on the soft pillow, those little plasticky electrodes here will still potentially trigger pressure ulcers. Even if it's bendable, as you can see here, it's still gonna put at risk of pressure ulcers. Because I'm talking about that, let's talk about contraindication. So the Ceribell is a bandana, as you can see, that will be applied on the head like this. So obviously, if you have a skull defect on that region, don't apply it, because you're gonna get that thing pressing directly onto through the skin onto the brain. So craniectomized patients should not have a Ceribell applied to them. Now, sometimes if it's high enough and I feel like I can apply it, let me take that risk, but you as a default rule should not apply on craniectomized Ceribell. If you have a big laceration, bruise, well, no, a bruise is not a contraindication, but a big laceration, what else? Burns. If you have that, we have an alternative technology that is softer with little sponges that we can apply. Otherwise, you're gonna apply this that is soft but still a little bit hard electrodes. When you turn from side to side, it's gonna clean the skin, remove the grease and the hair. It's gonna push the hair away. So you turn from side to side, and you can see it mobilizes that those prongs that are made of a bendable plasticky thing. And you're gonna then plunge down the plunger. You can see that circular thing above the circle here. The plunger will plunge down to the circle, and you're gonna see it, the gel will come out. Sometimes it's a little bit hard, so use your thumb or two fingers, like two thumbs like this, and plunge down the plunger to the edge of the circle. And I hope you can see on the video, it's releasing some gel that will create an adhesion between the scalp and that plasticky electrode. There's 10 of them. It will give you 8 channels, 4 channels per hemisphere, and you can see it says back for the occiput here, and you just leave it right above the eyebrows. Don't put it too high, sometimes it slides up, so you put it like this, and it's right above the eyebrows on the forehead. Don't put it too high, because we want to capture the frontal lobe, the temporal lobes, not the vertex. The vertex is not captured at all in that montage. So it's true that focal seizures at the vertex, let's say a superior sagittal sinus thrombosis, you want to know if they're seizing or not. That's not going to be ideal to use that. Just to continue and finish the application. So you roll a towel in the occiput to lower in the nuchal area in order to lower the occipital pressure. You push their hair back. You apply the bandana right above the eyebrows and to the back of the head. It's on the picture when you open the box. You plug it to the Ceribell recorder. You turn from side to side. It says 7 times. It doesn't have to be exactly 7 times, but you're just cleaning the skin and pushing the hair away. Go back to the middle so that you see your number here, and use your 2 thumbs to plunge down the plunger. It will release the gel, and the adhesion, the impedances will go back down to the bare minimum. When it's below 10 kilo ohms, it's going to turn from red to green for each of the 10 electrodes. If you have like 8 or 9 of them that are green, and you still want to proceed, because don't mess around with like trying to exactly have all of them green. You can still proceed, but then the recorder will always alarm, check electrodes, are you sure you want to continue without fixing your electrodes. So hopefully you will have all of them green, or maybe 1 or 2 of them that are with poor impedances, and you proceed to recording. It's asking you then the MR number, the date of birth, who's applying it. Don't worry if you don't want to put your name. It doesn't matter exactly who's the name of the person that's ordering the study. And then it's going to ask you where is it in the ED versus ICU, and it's going to tell you what type of pathology. All those things are just for QA purposes. At the end of the day, we know what the pathology of the patient is, and that's just for sort of a stratification and a classification of our studies. Yeah, at the end of an hour or between 1 and 2 hours, you remove. Only if I tell you, you know what, we don't have an EEG tech, there's never going to be a conventional EEG, and I saw some equivocal pattern, it's maybe a highly epileptiform pattern, and I want it to be running longer. Only in those in those contexts should you continue longer than 2 hours the study. The reason for terminating it between 1 and 2 hours is because there's an EEG code that is tied to that. When it's less than an hour, it's less precise, and the code is different in billing. When it's above 2 hours, then it's called a long-term monitoring study, and classically we should not use those kind of screenings for longer than 2 hours. The code can become different, but then there's repercussions onto that. Yeah, terminate it between 1 and 2 hours. So let me go to E64 for those who want to put their hands on that and put it on their own head, or look at the recorder and make sure that we're all very facile with using that without errors. So I'll go to E64 for those who are present today. Thank you.
Right. Thank you very much.